Dr. Kaveh here to talk about perhaps the most disturbing case I have ever come across in medicine involving nothing short of medical PTSD, which, as you know, is a betrayal of trust. A betrayal of trust when patients are at their most vulnerable. And in this case, specifically here in the operating room, where we're naked, where we're fasting and hungry and cold, and entrusting our lives to somebody. And when somebody betrays our trust that we give them in this incredibly sacred moment, it is absolutely disturbing. And I'm actually going to show you the video. I'm going to cut to the chase for you and show you exactly what the incriminating evidence was here. Let's look at Dr. Ortiz here. He just walked away from a cooler. Watch him again as he comes in, a warmer. He's got a bag of IV fluid. This is an anesthesiologist, and this was what probably sealed his case. He goes into a warmer, he's putting something in there, and he's taking something out. What he put in there was what would cause nearly 10 or 11 patients, at least maybe more, and even a colleague of his, to nearly pass away after a routine elective surgery, and in one case, just actually trying to help a colleague. This is the most bizarre and disturbing betrayal of trust I can imagine, because it ended up in patients after routine and elective surgery, with one exception that I'll tell you in a moment. It's one of his colleagues who he poisoned, leaving the operating room hypertensive, tachycardic, and eventually pulseless, requiring shocks and CPR, but not responding to those normal shocks and CPR and epinephrine because of the unique poison that he used that I'm going to tell you all about. And I'm going to show you what the antidote was that nobody ever knew because of how he chose to poison his patients using liposuction medications. I do need to acknowledge everyone who has had medical trauma. I hope never in a capacity this egregious, but it's very real. There's no question about it. And patients come to me from all over the world having experienced gaslighting, having been blown off. In this case, exemplifies so much of how that betrayal of trust can lead us to second guess ourselves. So just to make it very, very clear what this individual looks like, well, here you go. This is Dr. Ortiz. That's him putting a bag of IV fluids into a warmer. The video that you saw, this is a screenshot from there. To the right is Dr. Kaspar, one of his fellow anesthesiologists in Texas, who died from receiving one of those IV bags that he had tainted. To understand how this all played out, we're going to go through the clues one by one, and I'm going to explain to you medically what happened with each of them at every step and why it confused so many doctors for so long. The first clue was when patients and supervisors were noticing that there was a very large number of complications in a short period of time, like 10, 11 cases between May through August in 2022. That's way more complications than you would expect from a surgery center in that period of time. They noticed that they were longer cases. Longer cases need more bags of fluid. Clue number 2 is that the bags of fluid were taken from a specific warmer. Why are IV bags put in a warmer? Simply because when you are under anesthesia, your temperature regulation is out of whack. We need to warm your body to prevent it from going hypothermic. And the fluids you receive in your IV should be warmed to help minimize that potential hypothermia, not hypotension. Clue number 3 was that these complications were found to occur when a particular anesthesiologist was at the center and not occur when that particular anesthesiologist was on vacation. This began to narrow down who a potential culprit was. It didn't help when an RN very early on notified authorities of a particular anesthesiologist that was refusing to receive IV fluids from the RN and insisted on getting his own fluids. This difference, I don't know if anyone can see the difference between these two bags of fluid. This is actually where this poisoning was eventually identified. If you can figure out what the difference is between these two, I'll give you a shout out. And also, by the way, if you know what this medication is here, which was the antidote that nobody knew to use because of his particular poisoning. Unfortunately, Dr. Kaspar, who was a colleague of Dr. Ortiz, was receiving an IV bag for hydration because she wasn't feeling well during this time period. And one of the bags of hydration that she received was one of the bags tainted by Dr. Ortiz. Dr. Kaspar died, and her autopsy found a particular medication in her blood, a medication called bupivacaine, which is a very close relative of this medication called lidocaine, which is a very close relative of the natural substance extracted from the plant, from the coca leaf down in Colombia. So anyways, that plant alkaloid has anesthetic properties. So this is now beginning to paint the picture of why were these medications even in the operating room, even in this surgery center in the first place? Well, it gets deeper because an 18-year-old, in one of these 10, 11 cases, an 18-year-old was one who had to go to the ICU after their surgery. 18-year-olds are typically healthy. They typically don't have problems with their heart that require resuscitation with medications like epinephrine. They typically don't need shots of epinephrine or shocks, from a defibrillator. They don't need CPR after surgery. Something about this 18-year-old led to an analysis of what was in the IV bag, which was found to have bupivacaine, lidocaine, and indeed epinephrine itself. So what happened? Why were all these ICU doctors, why were all these patients so confused? Well, they were effectively gaslit when they're told they're getting a bag of IV fluids, they're getting anesthesia, and instead are ending up with ventricular tachycardia or ventricular fibrillation. I want to take a quick second to look and see if anyone has figured out the connection here. I'm looking at the all of your comments. Hey, Caitlin, by the way, total sidebar, but I hope your wedding video is going well. Who else was able to figure out that the doctor, yes, doctor poisoned some people, but what was the connection here between these medications? Caitlin, I agree with that as well. I'm not seeing anyone who's going to get a shout out here about what went wrong specifically. Okay, well, I'm going to cut to it then. When someone gets liposuction, you may or may not know that the surgeon has to, what's called tumesce the abdomen, if that's where the fat is being extracted from. You have to inject large volumes of fluid, stuff like this, but you can't just infuse fluid. You need to also numb the area with that fluid if you want to help minimize the pain after the liposuction. So we mix the fluid with local anesthetics like lidocaine and bupivacaine. They numb the area so that even though the patient is asleep under general anesthesia, they won't have as much pain, so we don't have to use as much general anesthesia. We also include epinephrine. Notice how small this vial is. This is 1 milliliter of epinephrine. 1 milliliter. This is a tiny, tiny amount. This is enough to kill me by putting me into ventricular tachycardia, potentially, fibrillation. Who knows what it would do to me, but it would really complete havoc on my body. Yet we put this in liposuction tumescent solution. Why do we put epinephrine? Because it helps constrict the blood vessels in the abdomen or the butt or wherever you're doing liposuction, and it helps prevent systemic absorption of the lidocaine or bupivacaine or whatever else is being used to numb that part of the body. Typically, lidocaine is used. Sometimes bupivacaine is used. When we use epinephrine and we prevent that sudden systemic absorption, meaning your body full on absorbing all that local anesthetic, it helps minimize the risk of toxicity from the local anesthetic, because local anesthetics numb nerves. If the concentration in your blood is too high, it'll numb the nerves in your heart and in your brain. What does that lead to? A heart that no longer pumps correctly, because your heart needs nerves to pump correctly to pump blood to your brain. If the nerves in your brain are not properly firing because of local anesthetic toxicity, you're going to have a seizure, you're going to go unconscious, you might die. from the combination of all your nerves being completely thrown into haywire. So the epinephrine prevents a rapid spike in your blood concentration of local anesthetics, lidocaine in particular. Now, the problem is that these medications do not go in a normal IV bag. They go in a bag of fluid that goes into your abdomen. So it doesn't go directly into your bloodstream because that would kill you very, very fast. Be very clear, it goes into your body, into like soft tissue, not into a bag that gets infused into your bloodstream directly. The other problem is that, as you can tell, all these medications are colorless. You can't, right? It's not like it's tinged yellow or blue or red. It's not like B12 that's methylated that's red. It's not like propofol that's white. It's not like, there are plenty of colors out there, methylene blue, whatever. You can't tell if they're mixed into a bag. So what Ortiz did is that he actually put them into an IV bag and would put the IV bag in the warmer. So when somebody came to grab a bag of fluid, that was clue number one, right? These were longer surgeries that needed more fluids. So people would get a bag of fluid from the warmer in the hallway. Then they would inject, they would let that infuse into the patient under anesthesia. And the patient would not, an awake patient will say, hey, I'm starting to feel numb around my lips. I'm hearing ringing in my ears. I'm not feeling so good. Those are the early signs of local anesthetic systemic toxicity. Local anesthetic systemic toxicity. That is the name of the condition that these patients would ultimately suffer from. Local anesthetic, systemic means body-wide, toxicity. If the patient's asleep, they can't tell you that the level is rising higher and higher until their heart peters out. And now you're in an emergency because you have to start doing chest compressions. The problem is that when the heart stops working due to LAST, or local anesthetic systemic toxicity, the normal algorithm for resuscitating a patient does not always work. Because this bag, I didn't see anyone answer in the comments, maybe I missed it. I'm so curious. Did anyone know what this is? I've talked about it in past videos. Yes, Lizzie, I am way behind in the chat. I'm sorry. What is this? Yeah, I don't see anyone telling me though, so I don't know. Well, this is Intra Lipid. This is 20% lipid emulsion. It's literally fat. It actually tells you on here, if you want to read with me here, it says how many calories it's got. 250 mLs, 200 kcals. You can actually read it. It's literally pure fat that we're infusing into your veins. The fat will actually absorb the bupivacaine and take it out of the heart muscle. So like Benjamin here says, lipid emulsion therapy. The fat will suck out local anesthetic that is binding to the sodium channel receptors in your heart muscle that is preventing your heart from beating properly. We rarely ever give lipid emulsion unless we know there is local anesthetic systemic toxicity. It is not a first-line usage at all. That's not the only problem though, because when someone is having LAST, in addition to giving intralipid immediately, we also use less epinephrine to resuscitate the patient. Usually in a code for you medical professionals, we are giving 1 milligram of epinephrine as part of our ACLS algorithm, our advanced cardiac life support algorithm. For LAST, however, you don't want to give that much epinephrine at a time. You want to give more like maybe 50 or 100 micrograms, literally 1/10 of the dose. On top of that, Ortiz was poisoning his patients and his colleague, it seems like for that matter, his own colleague. Who does that, right? He was poisoning their bags with epinephrine in them. So you already have epinephrine at toxic levels in your bloodstream. The algorithm typically involves giving whopping doses of epinephrine. But if you give that to someone who's already got way too much epinephrine, you are just wreaking more havoc on the body. This is leaving doctors totally confused. Like, what is going on? Why is this patient not responding to our emergency treatments? On top of that, as you might know, In the ACLS algorithm, we sometimes give lidocaine as an antiarrhythmic. You can give amiodarone, but some older algorithms still use lidocaine. These patients had local anesthetic systemic toxicity. The last thing you want to do is give pushes of IV lidocaine in someone who is suffering from a lidocaine/bupivacaine systemic toxicity. Literally every part of our algorithm is broken except for the chest compressions, the high quality CPR, and the shocks. And on top of that, what went wrong with the bags? It was later found when they were looking at the bags. This is what, if you're in the hospital, if you're in a medical profession, be aware of this. Bags like this are different than bags like this because they have a wrapper around them. This wrapper, you'll know if it's been punctured. You should at least be able to tell if there's somewhere, if someone were going to poison a bag that's got a wrapper on it, there's going to be multiple holes going through here. There might be a leak inside the bag. But if someone is handing you already an unwrapped bag, you need to really look at the end and see this is where you inject medications. For those of you who don't know, you unplug this here to spike it to get IV fluid slowly infusing out. But if you want to inject medications in, you inject it through this port here. You need to be super, super Hawkeye to find the little puncture holes, you can barely see them in the camera, in this area here, because these are very small needles. You won't see it. So if you're ever getting fluid, try to get one that's in a wrapper that has a much less chance of being tainted than one that's already been opened. Now, of course, I don't want to fearmonger. These are very, very rare events. But when it was looked back to see what went wrong in these 10, 11 patients between May and August, they were unwrapped bags that someone was putting inside the warmer that had the medications, these colorless medications, very potent, mixed into them. You don't need more than 1 or 2 cc's to kill somebody of these medications. You cannot tell if someone has added 1 to 2 cc's or 1 to 2 milliliters in a bag of 1,000 milliliters, because you're not going to be able to tell the difference on the fluid level. That's simply such a small amount. This medication is so potent that you would never tell. What is the takeaway from all of this? It's not to be a fearmonger. I'm not saying to not get surgery. This is one anesthesiologist in a big country. There are, of course, horrible people out there. And medical PTSD, it all comes back to what we started with, the betrayal of trust. I don't want you to not speak up for yourself. If you feel that you have been gaslit, I've been gaslit by doctors, and it blows my mind, the incredible narcissism and entitlement and grandiosity that some people have. Fortunately, it's not most doctors in my experience, but all it takes is one. And I've had far too many patients who have been gaslit by one doctor and have foregone so many medical treatments. And all I want you to know is that you need to speak up. You need to feel empowered to advocate for yourself. If you know someone who has been scratching their head, why did the doctor do this to me? Why did they say this to me? Please be empowered to speak up. If not with that doctor, with another doctor. You can watch my videos on how to respond to someone who's gaslighting you in the medical profession so that you can advocate. It happens too often, hopefully not at this degree of utter insanity and truly egregious and disgusting betrayal of trust. But all it takes is a couple of small ones to compound into patients that come to me that have lost so much hope, not only in doctors, but even in themselves. And if you've lost hope in yourself, it's very difficult for a healer to heal you. With that said, we're going to launch into our Q&A here. Just as a shout out, if you appreciate how I break down the secrets of medicine, please join our exclusive access. If you have been betrayed and you have medical PTSD, you can always learn more about my clinic in San Francisco. But remember that you have more power over your health than you've ever been told, and you deserve to have that self-compassion to go past medical PTSD and the trauma that others in positions of power may have caused onto you. Well, chasing the wild, you are very, very welcome for that. Stephen, good to see you. I don't have my book written yet. One day, hopefully. Courtney Frazier, I had medical PTSD because of what happened in February. I felt so uneasy. I'm sorry. And I want you, like everyone else who has had this experience and not ignore it. It's like when someone is aware under anesthesia in the operating room. The worst thing that one can do is to pretend the awareness did not happen. You know what the first line, the first action you need to do if a patient tells you they thought they were aware of something in the operating room when they were supposed to be asleep? You need to have an emergent psych consultation. It's one of the few psychiatric emergencies. There are many psychiatric emergencies, I shouldn't say that. But in the setting of surgery, I can't think of any other psychiatric emergency other than awareness. Yet how many doctors don't even think to ask about it and pretend like it never happened? Heidi, so good to see you, and thank you for the kind comments. Peace back to you, Jay. Peace. And Carrie Ann, I totally agree. Absolutely crazy, but also a lot that we can learn from. Katie, thank you for the kind comments. So good to see you. I hope you're doing well in the land down under, as they say. Lotus, very kind of you as well. Hey, Julie is saying the doctors unfortunately will not discuss what happened. Everything is a big secret. I finally had an NP, nurse practitioner, that discussed what happened. Yeah, Julie, I agree. You know, there's this ivory. I'm going to be full transparency. Medicine is like this ivory tower that, for many financial incentives, has been built to keep many individuals out. And the problem with medicine, as you know what? Give me a shout out or comment below, and I'll give you a shout out if this is you. And I know there's many of you. Have you ever felt like information was withheld so that, do you feel that information that was withheld prevented you from better taking care of yourself? So to be clear, the ivory tower leads to patients not getting information and to not being able to heal themselves and advocate for themselves and empower themselves with knowledge. I don't want to sound cliche, but knowledge is power, like Einstein said so long ago. Too many patients don't have the knowledge to advocate, to take control of their health. Stephen, thank you so much for that super thanks. PTSD and Lyme disease patients, Scott, if you're referring to chronic Lyme, this is a challenging branch. Just like how any chronic viral illness or bacterial infection can lead to all sorts of vague complications in the long term. Have you heard of chronic Lyme? Have you heard of long COVID? Have you heard of HIV syndromes? There are, after hepatitis viruses, there are so many. Mononucleosis after EBV infections. There are going to be all sorts of long-term sequelae. We just don't know about them very well. Now, some of them we do know well, like after chickenpox, varicella, you can have zoster. So we know about that one. We treat that one. It's got very defined symptoms. But anything that's more vague, we are very quick to not acknowledge the organic underlying cause. This is why I do what I do in my clinic, because you got to address the root cause. What is the chronic inflammation after a viral illness or bacterial infection done to the body? And long COVID patients, in case you don't know, in San Francisco, we use ketamine and NAD and stellate ganglion blocks to help address the wound up sympathetic nervous system that has been wound up because of chronic inflammation, and that fight-flight response from the wound up sympathetic nervous system further feeds in to chronic inflammation or hyperinflammation. So that's what the goal of our therapies are to help reduce the sympathetic fight-flight response in hopes of reducing the chronic inflammation. It does not work for everyone, but I'll tell you, the number of patients that have come who have been completely gaslit and hopeless compared to the number of patients that find treatment is a very favorable ratio. That find symptom relief, very favorable ratio. And Kathy, you're so welcome. Man, so many kind comments. I appreciate all of them. Thank you. I'm going in for a lower GI. Should I be scared? Do you mean a colonoscopy by lower GI? If not, well, if so, I would hope you wouldn't feel scared. Hey, thank you, Lizzie. I appreciate it. The IV has to be wrapped before using it. Well, Susan, all I'm saying is that if somebody has a wrapped IV, it's less likely that it's been tainted with than one of these already pre-peeled IVs. That's all I'm saying. I'm not saying everyone should insist on a peeled IV, but it is worth considering what went wrong in this process. How do you know How can we be certain the IV bag is in plastic if we're medicated? Well, you don't know. This is for mental health professionals who are dealing in this space. That's all. Susan, hey, thank you so much for your agreement. I hear you. And I agree that long COVID sucks, Rachel. I'm sorry. It sounds like you might have been suffering from it. Carrie Ann, asking good questions, asking lots of questions is not wrong. Being respectful and listening to the answer is crucial, both for the doctor and the patient. And Jody, hey, back to you. When a doctor fails to explain test results or doesn't do more than basic testing, well, that sounds like a lot of modern medicine to me, doesn't it? When the story broke, she told fellow anesthesiologists she was taking IV home to hydrate and it was intentional. Did not know he was doing it to others. Well, this is based on my reading from the DOJ. And thank you so much. As a reminder, Heidi, please hit that like button if you're learning something new. I went into a nuclear stress test just because the doctor ordered it. And I was in his office. Oh, it was in his office. I'm sorry, Courtney, that you had what may have been an unnecessary test, though I cannot know for certain. And I agree that root cause analysis is very important, Wendy. Agreed. How scary is it to have a heart valve replaced? Well, cruising on the high seas and travel, there are percutaneous valve replacements, then there's open heart valve replacements. Which one are you talking about? They both have risks. They both have many benefits. If we can do them with minimal invasiveness, like going through the groin, without having to saw open the sternum, there's a lot to be asked for and a lot to be expected in a minimally invasive approach, but it depends on the individual. And Jane, I'm sorry that you had this experience with mono. You have nailed it, how a particular illness can have lifelong changes. It's not just long COVID. It really is not, because you know about mono. I'm sorry you had that experience, but I hope that you can advocate. I got to say that myalgic encephalomyelitis, or what we call chronic fatigue syndrome, please leave a comment if you're aware of this so you can help educate others. I don't think this just comes on its own willy-nilly. It might in some individuals, but the debilitating fatigue and the absolutely excruciating pain that also often accompanies it if it's with fibromyalgia often has some trigger in the past that we believe might be viral in origin. Not all patients, but probably something in the double-digit percentages, 30% or so. But if we don't even acknowledge that an initial inciting infection can have lifelong consequences, we are just wasting time. And if you're a patient, you don't have time to waste when it's your body that's been fatigued and your body that's been in pain. And the next video that I'm going to do, or this future video, is going to be specifically on when doctors sometimes, I don't take this the wrong way, but how much it helps for a doctor to have experienced pain to be able to treat patients who are in pain. If you've ever thought about that, let me know, because it's a very, very touchy subject, but kind of goes into this gaslighting thing, which can be abusive if a doctor doesn't know what a patient's going through. I've had my own experiences that I want to personally share next time. And I hear you on the chronic fatigue. Mama Bear, have your questions answered before you're put under. It's your body, of course, absolutely. I will ask that I'll say it's important to start asking your questions early, because if a lot of questions come up the minute before you go under anesthesia, you might not get the answers that you want, and you might not have enough time to process the answers. So your advocacy, your engagement earlier on in the surgery process, when possible, behooves you as the patient. For years, doc told me there was nothing there. I'm sorry that you had that. I wonder what the underlying reason was. Now, chronic pain after gallbladder surgery, this is a different. So we're talking about viral and bacterial infections having long-term consequences, but you need to know that anytime someone has surgery, there's always a risk of post-surgical pain. Were you aware of this? I don't think patients are ever told this. Acute pain can transform into chronic pain, whether from gallbladder surgery, from orthopedic surgery, whatever. And this is why the human body needs to have the right support inside and outside to prevent the insults that can happen from physical traumas, viral infections, etc., from turning into lifelong complications. I'm not saying it's anyone's fault, But I am saying that the more prepared the body is and the better support it has internally and externally, the less likely I at least believe it is for that body to transition to a chronic disease. What if the cardio can't see me before my surgery? Well, talk to your anesthesiologist, Jana. I can't tell you on here. I'm sorry. Just as a heads up, 3 weeks of post-surgical pain is not uncommon necessarily. Chronic post-surgical pain refers to pain after surgery that goes on like 3 months after the surgery. I hope that your surgery gets better soon. Rachel, aren't the surgeries to prevent pain, not make it worse? Well, Rachel, I don't disagree with you, but have you heard of failed back surgery syndrome? Does anyone here know about FBSS? Many acute insults to the body, if the body is not prepared. Acute insult means like what? Physical trauma, being hit by a car, having surgical trauma, having psychological trauma, viral infections, etc. The body isn't prepared. This can transform into chronic pain for any number of reasons. The spinal cord being overly sensitized, what we call the wind-up phenomena or central sensitization. I mean, there's many reasons, future videos, but don't think that medical intervention necessarily means cure, because that's absolutely not the case. In some cases, it is. I love modern medicine. Don't forget, I'm an anesthesiologist. I support Western medicine in the right context. For my last surgery, they gave me xylazine. Hey, Gene, xylazine is not used in the United States in human beings, so I kind of doubt they gave you xylazine. They may have given you dexmedetomidine, but xylazine is a veterinary medicine, at least in the US. I hope they didn't give that to you. The AMA gave you PTSD. I'm sorry to hear about that, Scott. Does deeper sedation, this is an interesting question, have to be requested by the treating physician prior to the procedure? Deeper than light sedation, considering as I'm having a procedure tomorrow, and my GI said it took 9 milligrams of Versed. Well, Justin, that's a lot of midazolam, 9 milligrams, but you should express that to your anesthesiologist tomorrow so that you get the right amount to start and the right amount as it's titrated once the procedure starts. I want to, a quick reminder, guys, this is not medical advice. This is information for you to consider and discuss with your doctor about. Please don't forget that. And also, if you're learning something new, do please hit that like button and share with others. You're so welcome, Justin. I'm wishing you the best for your procedure tomorrow. I'm sorry, Sterling Hawk, that speaking with the manager did not change anything. But hopefully, if another person speaks up, eventually karma will hit, the karma train will hit that individual, if you know what I mean. And yes, Dina, I totally agree. I'm just learning about stronger meds, and they really do scare me. And yeah, I agree. These meds are literally 1 milliliter. That's how strong these medications are that can wreak havoc in the body. There's a time and a place to use them properly, and that's why we go to medical school for so many years. Hey, one last question, and then we're going to move on. Juliana, doctors treat people with chronic pain like we are crazy. Well, Juliana, it's not just chronic pain. It's patients that are female, that are minorities, that don't speak English, that have chronic pain either musculoskeletally, neuropathically, migraines. Bottom line, if you cannot prove it on a laboratory test, you are susceptible to being gaslit. I myself have. It sucks, totally inappropriate. And this is why I hope that if you're here listening, if you have been gaslit or if a loved one's been gaslit, remember that you have more power over your health than you've ever been told. And that if you can advocate for those who have been gaslit, I hope that you can help turn the tide. The more patients advocate, the more doctors have to listen. If not, they'll lose their jobs. I'm not saying to be mean to doctors, but I'm saying to be open in your communication with them and demand respect and give respect. Rick, thank you for the kind super thanks. Thank you for your work as a registered nurse for all these years. And you're right that there is good and bad, but when the profession of healing falls into bad, it's often very, very bad and egregious, like the case of Dr. Ortiz. It's not to be afraid of medicine, but it's about learning to be your own advocate in medicine, because you are the greatest shareholder and stakeholder in your own health. Until next time,